have two out of the box questions. Usually, the Viva, they give you straightforward cases like renal failure, ESRD patient coming for renal transplant, or post-transplant patient suffering some incidental problem requiring surgery. But here I thought we'll just try to test your understanding of patients waiting to have a transplant with renal replacement therapy needing an incidental surgery. And another important progress that we are making in the transplant program, namely cardiac and lung transplants, which are being done very frequently nowadays. So in future, you may be anestheticing patients who have had a heart transplant or a lung transplant for an incidental surgery. So the batch which is going for exam, you have still some more time. So I thought instead of routine straightforward exam cases, I will just give you some different type of present case where you have to think a little bit more and then prepare your answers. So with that idea in mind, we have given you the two questions. And I think Abirami is going to present on patient with ESRD coming for bilateral nephrectomy. Okay?
Yes, sir.
Right. Okay, you can go ahead.
Good evening, sir. My case history is a 45-year-old male on thrice-a-week hemodialysis for end-stage renal disease for 4 months, posted for bilateral excision of polycystic kidney disease. My concerns are it is a major surgery and the potential for blood loss and fluid shifts, and it is a large incision and any dialysis and its complications, CKD associated systemic changes, and it is a multidisciplinary approach. Goal: we should optimize the comorbidities and maintain hemodynamic stability and manage fluid and electrolytes and avoid nephrotoxic drugs. History. Initially, we should ask when was CKD diagnosed and how long he was on hemodialysis. Any history of gradual decrease in urine output, and any history of breathlessness, pedal edema, chest pain, or palpitations. Any history of loss of appetite, nausea, vomiting, anorexia, any abdominal discomfort due to the large cyst, and any history of native urine output, daily fluid intake, or any residual renal functions, and any history of associated comorbidities like hypertension, diabetes, CAD, and any other bone disease. And also we should ask about any association of polycystic liver disease, any diverticular disease of colon, and any valvular heart disease, any aneurysms in the aorta and brain, associated history. And it is the most common autosomal dominant. We should ask about a family history, runs in families. Any history of renal artery embolization prior to the surgery. Drug history, any antihypertensives like ACEs, ARBs, diuretics, any calcium channel blockers or beta blockers, phosphate binders, any anticoagulants, and erythropoietin. Dialysis history, indication when was elective or frequency like thrice a week, twice a week, or any weight gain, any pulmonary edema due to skipping of it. Time of last dialysis, and a site AV fistula or AV graft, any hemodynamic instability during the initial stages or any intradialytic complications, and body weight before and after dialysis, and any heparinized or not. Examinations, any pallor, bleeding tendencies, edema like facial or pedal edema due to fluid overload as scratch marks. Vital signs we should check for autonomic neuropathy if associated with diabetes mellitus, and cardiovascular, any flow murmurs, signs of left ventricular hypertrophy or failures. Respiratory system, any crepitations due to fluid overload and need for dialysis. And AV fistula locations and dialysis line, we should protect from BP, cuff, and needles. Like we should check for functional status of AV fistula, and airway assessment in case of chronic diabetes, any loose tooth, and uremic stomatitis. Investigations, CBC, like hemoglobin for ruled anemia, WBC infections, and platelet count. RFT, electrolytes, burn, creatine, sodium, potassium, calcium, and bicarbonate, and coagulations and LFT. Any previous ultrasound when was diagnosed this polycystic kidney disease, a CT, MRI to check for anatomy, and a chest X-ray, cardiomegaly, pulmonary edema, any pleural effusions, ECG for rule out any ischemia, arrhythmia, left ventricular hypertrophy, hyperkalemia, and conduction block. Echo to rule out any check for EF, regional one motion abnormality, and in pericardial effusions. Preoperative optimization, correction of anemia, iron, folic acid, and erythropoietin can be given, and should correct hypertension, antihypertensive, and should discuss with nephrologist, and correction of hyperglycemia, and correction of coagulopathy, any platelet dysfunction, cryo or desmopressin can be given. Optimize cardiac and pulmonary functions, fistula care, and blood grouping and cross matching must be done because it's a major surgery. Pre-op dialysis 24 hours before surgery, or at least 6 hours lapse between dialysis and start of surgery. Continue cardiac and antihypertensive medication and withhold any ACE inhibitors, ARBs, to avoid hypotension intraoperatively. Anti-aspiration prophylaxis, ranitidine and metoclopramide can be given. Anxiolysis and if on any immunosuppressives, and NPO guidelines should be given. Intra-op monitoring, standard ASA monitorings, and IBP to rule for check ABG and blood samplings, ECG, saturation, temperature, and urine output. Central line for fluid and blood bleeding management. Avoid nephrotoxic drugs. Induction, pre-oxygenation, and RSA in case of any autonomic neuropathy. Avoid agents causing significant hypotension and prolonged metabolism. Injection fentanyl 1 to 2 max per kg IV. Injection propofol 1 to 2 mg per kg. Avoid Saxa if potassium is more than 5.5. Atraca can be used. It's eliminated through Hoffman eliminations. Avoid panchronium. It is renal excretions and it causes tachycardia. We should attenuate the intubation responses. Intubate with cuffed endotracheal tube. And regional, and if no coagulopathy, epidural can be inserted because it's a central incision for pain management. Maintenance, oxygen, air, and with ISO. Maintain normothermia. Opioids for analgesia, especially fentanyl and remifentanil, can be given. Avoid morphine. This morphine 6-gluconide, which is excreted renally, and DVT prophylaxis should be maintained, and maintain normothermia. Fluids, aim euvolemia, use crystalloids, avoid potassium containing fluids, and replace blood with PRBC, blood loss. It is a bilateral nephrectomy, have significant blood loss due to enlarged kidneys. Check ABG and potassium periodically and treat if any hyperkalemia. In case of extubation, titrate neostigmine, it is renally excreted. Only extubate if fully awake, normothermic, and stable hemodynamics and adequate respirations. Post-operative care, analgesia, multimodal analgesia, avoid nephrotoxic drugs, fluid strict input-output charting, and plan for hemodialysis session and discuss with nephrologist. Monitor for bleeding, hyperkalemia, and hypotension, pulmonary edema. Avoid nephrotoxic drugs. That's it, sir.
Okay. So you have dealt the case scenario mainly from the ESRD and renal replacement therapy angle. Am I right?
Yes, sir.
Any challenges in doing a bilateral nephrectomy in a patient in the same sitting?
Is
Did
a
you
blood
think of
loss?
it?
Blood loss.
Huh?
Blood
Blood
loss.
loss. Okay. Yeah. Is the blood loss the main criteria here?
Renal should preserve the renal function.
There is
Dialysis.
no renal function. Already he is on renal replacement therapy. Thrice a week dialysis means absolutely it is a grade 5
Yes.
GFR, isn't it? Less
Yes,
than
sir.
15 ml per
Okay.
minute. Okay. So that doing bilateral nephrectomy in the same sitting is also a challenge, because what is the position they will adopt for nephrectomy?
Left lateral.
Lateral position with the kidney bridge raised and breaking it, isn't it? So
Yes, sir.
imagine a situation where you have to do first right side, you put the patient on left lateral, bend the table, open up, finish the surgery, then close the wound, apply dressings. Then the entire patient has to be turned to the right lateral, expose the left side, do the surgery on that side. So the challenges are there. This case scenario actually I experienced. I have done a case like this during my transplant days, where a patient had two huge polycystic kidneys and they did not have space to keep the transplant kidney. He was planned for a transplant. So before that, because the size of the polycystic kidney was so large, unless you remove that, there was no space for the, even though it is kept in the right iliac fossa, as all of you know, it's a heterotrophic transplant, not done in the real position. So it was a challenging case. And the second reason they wanted to remove it is was getting recurrently infected. The polycystic kidney was having recurrent nephritis problem also. So they don't want the source of infection remain before the transplant being done. So that was the reason why they wanted to do the nephrectomy in one sitting on both the sides. Okay. So here the challenges of the surgery also has to be taken into account. So you imagine intubating a patient in this supine position, then turning them to right lateral. You have to take care of the IV line. You have to take care of the blood pressure monitor, the tube, everything. After that, you do the change to the other position in the anesthetized state. So that also has to be thought about. So that is one thing. And when you do bilateral, as you said, surgeon has to be very careful to avoid too much of blood loss. We don't want to give a blood transfusion unnecessarily in a patient who is likely to go in for a transplant surgery later on. Okay, so there may be problems with the cross matching and tissue matching. So that is another important challenge that we have to remember. Okay? And with regard to the discussion on the patient who is already on renal replacement therapy, you have correctly enumerated all the questions why he was initiated on renal replacement therapy. But the initial picture has to be found out from the history. Whether the renal replacement therapy, that is hemodialysis, was it started as a elective procedure, knowing that the patient is going in for ESRD, by creating a fistula, allowing the fistula to mature. When patient had some of his own native urine to prevent him from going in for fluid overload, then you start the patient on hemodialysis utilizing the AV fistula created in the upper limb. Okay, that is one method of doing it. Another, some patients who are not aware of the ESRD situation suddenly land up with either fluid overload and pulmonary edema, or severe vomiting leading because of uremia and high creatinine, or come with a seizure because of the uremic encephalopathy, or come with a arrhythmias because of high potassium causing ventricular tachycardia, which may at any time go on to ventricular fibrillation and arrest. So in such situation, what do you do when a patient lands up with either pulmonary edema or hyperkalemia or acidosis or the uremic encephalopathy? What is how to manage that patient?
Vascular
You have to go for IJV cannulation and emergency dialysis. So that history is very, very important, because in the case scenario I have given, the patient is on renal replacement therapy for the last 4 months. Okay, that is the scenario given. So when recent renal replacement therapy, that initial history of how hemodialysis was initiated in the patient is very important. Then how he tolerates, is he able to withstand the withdrawal of fluid and then pumping it back into the patient, whether he is able to tolerate it, his hemodynamic stability, is it maintained, or does he go in for hypotension and corrected with a fluid infusion to bring back the blood pressure? Does he still have any peripheral edema, which was could have been there when he's attended the nephrology clinic initially? And whether now the edema has decreased or completely removed by adequate dialysis, because we have to find out the efficiency of dialysis and its response also. And another important point we have to remember and present in all these cases is when to do the dialysis before the planned surgery, because this is a planned elective surgery. Bilateral nephrectomy for polycystic kidney is not an emergency. They know that it is present there, and so they plan it as an elective procedure only. So we must time the time of hemodialysis before surgery, which should be ideally within what time?
24 hours.
Within 24 hours. And if you do 24 hours, normally we heparinize the patient during dialysis to prevent the clotting in the circuits. Okay? So what does that can have? Does it have any effect on the surgery?
Bleeding.
Bleeding. So if the surgeon wants to avoid bleeding, what other precaution the nephrologist can help with? We can do heparin-free dialysis. Okay, there is a technique called heparin-free dialysis. So it's major surgeries when we are planning to remove both the kidneys. The nephrologist, as you said, it's a team approach. So the surgeon, anesthetist, and nephrologist, they can discuss about this, and the nephrologist can order for a technique called heparin-free dialysis. How is that done? Any idea? How do they do the heparin-free dialysis? They don't administer heparin intravenously. How they prevent the clotting of blood when the blood is being drawn out of the body, extracorporeal, and then circulate it into the dialysis machine and pump it back? How is clotting prevented in heparin-free dialysis? All of you would have heard the term heparin-free dialysis, isn't it? But Muthupriya, Soundarya,
Yes, sir. Sir.
any idea how is heparin-free dialysis is done?
Yes,
Dr. Anusha is also there. Anusha, MD, you have already finished MD? Okay, okay. So here what happens is there is a coating of heparin in the tubings that are used. Okay, so that prevents clotting. Okay, it is almost like your normal endothelial lining. So that will prevent clotting. So that is what is called heparin-free dialysis, where they use a special circuit laden with heparin. And so that is the preparation. And you are worried about hyperkalemia before surgery. So we must always check the potassium. And we must get the history of why the patient developed the ESRD that you said. And one of the main causes for ESRD is diabetes. So if the patient is a known diabetic and that has produced the so-called diabetic nephropathy, and that has led to the end-stage renal disease requesting or requiring renal replacement therapy, then you must know what is the glycemic control. If the patient has got adequate glycemic control, what will happen to the requirement of anti-diabetic drugs in patients who develop ESRD?
Yes, sir. Less rate.
Will they require the same dose, or will they require increased dose, or will they require a decreased dose?
Less dose, sir. Insulin
Why
won't
less
be
dose?
It won't be cleared off in a CKD.
So native insulin is metabolized at the renal level. Okay, endogenous insulin, which is produced by the beta cells of the islet of Langerhans, metabolized and excreted by the kidney. When patient develops CKD and ESRD, this metabolism is delayed. So the endogenous insulin level availability becomes more. So what happens as the patient who is a diabetic, who develops diabetic nephropathy, gradually you will find his episodes of hypoglycemia will increase when he is taking the same dose of diabetic drugs which he was taking before he developed the CKD. Okay? So that is how the nephrologist or the diabetologist will find out that they are developing diabetic nephropathy and start reducing the doses of the oral hypoglycemic agents or the insulin that is being administered to the patient. Okay? So that is a very important evaluation that you have to do to prevent intra and post of hypoglycemia also. So you have to reduce the doses of anti-diabetic drugs and insulin if you are taking it. And with regard to fluid balance intraoperatively and postoperatively, you said about central line requirement. Here we are not going to infuse large amount of fluids or anything here. So there is no need for any central line. We are not going to maintain a CVP or anything here because here we are worried about overloading the patient rather than underloading. So here we need only a minimal goal-directed fluid therapy to maintain adequate perfusion to other organs. Post-op, you must plan for resuming the hemodialysis as early as possible so that he doesn't go in for any electrolyte imbalance or fluid accumulation. Okay, that is the more important worry that you are. And with the patient having undergone such major surgery, again post-op also for 1 or 2 dialysis, it is better that the heparin-free dialysis technique is followed instead of giving routine heparinization and following the doing the hemodialysis in the post-op period also. Okay, so these are all the points that I would like to add to your otherwise good presentation. I will just share the is it visible?
Yes, sir.
So I just mentioned ESRD patient on hemodialysis for bilateral nephrectomy because of the problems here. As I always said, whenever case scenario is given, you think of what are the challenges in this case first as a initial, so that your thought process can be organized to present according to the problems that are faced in this. So the true problems here I can perceive are, one is the patient who is already on renal replacement therapy and the effects of renal replacement therapy that is hemodialysis, and the surgical aspect is a bilateral nephrectomy which will require changing the position of the patient intraoperatively. And of course, as you said, the problem of blood loss also has to be taken into consideration. So the important systems that will be affected in patients with ESRD is first and foremost is the cardiovascular instability. Most of them may be hypertensive patients, and before the onset of or starting of hemodialysis, they usually go in for fluid accumulation and fluid overload, which starts initially as facial puffiness, pedal edema, and then gradually goes on to increase the volume load in the circulation and produce even sometimes pulmonary edema, which may warrant emergency treatment. And second important thing is they usually have fluid and electrolyte imbalances, and their drug metabolism is also altered. So all drugs that are eliminated by the kidney, we have to be very careful, and especially before the start of phase T, sometimes the ESRD itself is drug induced, like chronic NSAID usages in patients with severe arthritic problems. Repeated and high doses of NSAIDs could have caused this problem. And the coagulation failure or coagulation alteration also happens in these patients. What is the reason for the bleeding or coagulopathy in these patients?
Platelet dysfunction, qualitative
It is thrombasthenia. It is called thrombasthenia. The platelets number may be normal, their activity is not normal. So they are very poor in getting, first of all, attached to the endothelial surface. So aggregation and
Aggression.
accumulation are different. So that is how the bleeding risk happens. Is there any drug to correct that platelet deficiency or ischemia?
Cryoprecipitate and desmopressin can be given, sir.
Desmopressin, very good. So do you give it intramuscularly or intravenously?
Both, sir. IV and IM.
Subcutaneous is the most common route. And they may have gastrointestinal issues. What are the gastrointestinal issues a patient with ESRD is likely to have?
Delayed gastric emptying, anorexia, nausea, vomiting.
What is the reason for anorexia and nausea, vomiting?
That uremic toxins.
Uremia produces a light coating on the gastric mucosa, okay, and makes it swell up. And that is the reason for the constant irritation producing a nauseous feeling. And also intake is reduced, so there may be nutritional problems. So gastric uremic induced gastropathy, that is called. What are the respiratory issues?
Pulmonary edema, fluid overload.
Overload. So it is secondary to the cardiac or hemodynamic instability. So perceived respiratory problems will not be there. Respiratory accumulation of fluid gradually can produce rales and bronchi before it becomes a overt pulmonary edema. Then autonomic neuropathy is a very important component of chronic kidney disease or ESRD. So why this autonomic neuropathy is important in this particular case? Is there any relevance?
Position.
When you change the position from supine to right lateral and then again supine and then left lateral for both side nephrectomy, there is likely to be a severe hypotension. So how to detect whether the patient has got autonomic neuropathy or not in the preoperative evaluation?
Orthostatic hypotension test.
History of orthostatic hypotension. Okay, then
sweating, tachycardia,
resting tachycardia. Okay. Then any objective evidence? These are all subjective.
Heart rate variability.
Pardon?
Heart rate variability.
Heart rate variability by doing an ECG. Okay. So this is a common question that is asked in the examination, sometimes in the theory also for the juniors. What is autonomic neuropathy? How to evaluate it? These are one of the common repeated questions in the theory paper also. So read about it itself. Then coming to the surgical aspect challenge is bilateral nephrectomy. The same sitting, change of position of anesthetized patient with attendant risk of ET tube or IV line dislodgement. They require a monitor adjustment. You have to change the BP cuff from the one limb to another, provided all the time you have to take care of the fistula. If the AV fistula is there in one hand, when changing the position, you have to make sure that the fistula is not occluded or compressed. So that is a very important challenge that you have to face. And there is a possibility of loss of sterility because after completing one side, they will apply the dressings and other things which are not totally sterile. So the other side, if you are not preparing properly, these people with already having a compromised immunity, they are likely to get a wound infection and septicemia can set in. So this is another problem. So these problems also have to be taken into consideration. Now coming to pre-op evaluation of a patient on ESRD, you must know what is the first of all the cause for the patient developing ESRD. It may be in the form of diabetes mellitus, hypertension, IgA nephropathy, and in this case it is a polycystic kidney. So as you rightly said, polycystic kidney may not only affect the kidney but other organs also get affected. So in my experience, I had a patient who had cystic disease of the several organs in the body, including the lung, liver, kidney, spleen, everywhere he had cysts. And it was a great challenge for me to anesthetize that patient, first for nephrectomy and then for transplant, because his lung also was the polycystic lung disease. So that was the thing. We have to make sure that the other organs are functioning normally. The second thing is timing and manner of initiation of HD, as I said, whether it was done as a planned procedure after creating an AV fistula, or whether it was done as an emergency through internal jugular cannulation. And patient's complaints to HD, whether he is doing it regularly at the prescribed interval of twice or thrice weekly, or sometimes, patients who are waiting, who have some native urine output, may require random hemodialysis once or twice to remove the excessive potassium or severe acidosis that they may develop. But here the history gives you that he is on thrice weekly dialysis. That means he is on a severe grade 5 ESRD. Then weight gain and weight reduction between dialysis is another important thing to see whether he is accumulating fluid excessively, and how much of weight is being removed during every dialysis, and whether he has any native urine. Some patients may have only 50 or 100 ml per day. Some patients may have a normal quantity of 1000 to 1200 ml per day also. So patients who have normal urine output quantity, that means they are eliminating the water, even though their urea and creatinine may be accumulating in the body. They are able to filter the water, and they will not usually go in for fluid overload. And even during transplant or other incidental surgeries, even if you err on the higher side of giving a little bit of excess fluid, they will be able to eliminate it. So this history of what is the native urine quantity is very, very important to decide the intraoperative fluid administration in these patients. And any history of fluid overload and pulmonary edema when they missed one or two dialysis. For example, patients on dialysis may need to go for some family function to some other place, and they get a dialysis done and then go to attend a function, and get delayed in returning back. At the time, they may miss one dialysis, and even missing a single dialysis, if it makes them go into fluid overload and develop pulmonary edema, that means they are very poor candidates. Their cardiac compromise is very, very unstable. So this history is very, very important to find out whether they are able to manage skipping one or two dialysis also by their native urine output or restricted water intake instead of going in for fluid overload and pulmonary edema. And whether they developed any dialysis disequilibrium syndrome during the initial phases. Because I said here the patient is on dialysis for the last 4 months. So the initial period, how they tolerated the dialysis is very important to find out whether they have already developed some autonomic neuropathy or not, which will be exhibited in the form of dialysis disequilibrium syndrome. And any recent plan for renal transplant. Now, the purpose of doing bilateral nephrectomy, as I told you, in the case which I had to deal with, it was for pre-transplant preparation. So, if the patient is being planned for a renal transplant, the main important thing is we have to avoid blood transfusion, as I told earlier. And the reason for the present surgery, it may be an oversized tumor or recurrent infection. And if it is infection, we must know what antibiotics to give so that it doesn't become a systemic infection like septicemia. And drug therapy, what are all the drugs patient is taking, that also we should evaluate, like antihypertensives, which antihypertensive is taking and whether it can be continued before surgery, whether he has been on steroids. So which patient would have been given steroids?
Immunosuppressive.
Among these causes I have mentioned, which patient you think would have received
IgA nephropathy.
IgA nephropathy. Okay, so these patients are initially managed with steroid therapy for some time before they go in for this ESRD and dialysis. So this history of steroid intake is important. Erythropoietin to maintain hemoglobin level. So what is the risk of erythropoietin?
Thrombosis.
Thrombosis can irritate the central nervous system. Seizures are possible. So all the complications, whether he has experienced any, should also be evaluated. And as I said, OHA dosage, whether it required any reduction because of ESRD, also has to be taken into account. Then pre-op optimization, timing of dialysis. As I said, the timing should be at least 24 hours prior you should do, and whether you can do heparin 3 and pre-op potassium, whether it is within normal limit, because hyperkalemia is one of the important complications for developing intraoperative arrhythmia, and life-threatening arrhythmias can happen. And the fasting glucose level if the patient is a diabetic. So these are the things that we have to know about. Then intraoperative management, you can think of GA with epidural, because this is a bilateral procedure and quite painful. Sometimes warranting even a rib resection because the tumor is or the kidney is so huge. It all will be very painful. So we can plan for a GA combined with epidural. But what is the caveat in giving an epidural? What should you evaluate properly?
Coagulopathy.
Coagulopathy, very good. So patient may have, if they have coagulopathy, you must avoid epidural. But if the coagulopathy is not there, bleeding profile is normal, coagulation profile is normal, we can plan for a combined epidural with general anesthesia so that we can avoid heavy narcotics like morphine, pethidine, NSAIDs. And the induction agent of choice will be propofol, especially if the patient is hypertensive. The blood pressure will be well controlled with propofol. So we can go for titrated doses, give it slowly, avoiding sudden hypotension. And the relaxant of choice will be atracurium or cisatracurium, as you know, because they are not dependent on elimination for the kidney or liver. And paracetamol, safe dose of 1 gram twice or thrice is safe enough. And we can use tramadol without any fear in these patients. And you can do controlled ventilation with air, oxygen, CO or isoflurane. And when you reverse these cases, use titrated doses of neostigmine, so that neostigmine is also eliminated by the kidney. So there may be a prolonged effect of neostigmine in the post-op, producing bradycardia and hypotension. And you have to have a guarded fluid therapy in these patients, so that you don't overload them intraoperatively. And antibiotic cover, avoid blood transfusion if the patient is planned for renal transplant in the recent post-op surgical period. And post-op care, plan for resumption of hemodialysis as early as possible. Continue antibiotic cover so that there is no infection occurring in these patients. Okay, so these are all the points that you have to remember.
So one doubt, sir.
Ah.
Can we give tramadol, sir?
Tramadol in doses of 50 milligram PDS is quite safe in this. It is not like morphine or pethidine. Okay, it's a weak opioid. It has got other routes of elimination, and action is also there. So tramadol is quite safe. But if the patient has got any history of seizures earlier, better to avoid tramadol because it reduces the seizure threshold. Okay, so that is why that the history of erythropoietin and seizures are very important.
So can we put midline incision and can we remove separate two incisions?
Pardon?
We can put midline incision and can we remove both kidneys, no, sir?
that will be difficult because both the kidneys are retroperitoneal. No, when you do midline, you have to encounter the intraperitoneally. You have to handle all the bowel and retract them and do it very difficult. So
Okay,
the
sir.
surgeons prefer to go in the retroperitoneal area by lateral position, and even changing the position is also not a big problem. But the transperitoneal is not advisable. Quite difficult. And nowadays, some surgeons may think of doing it laparoscopically also. That is even
Sir.
more challenging. With a huge kidney there, the space will be very, very limited. That may be even more time consuming and more challenging than the nuclear. Right, no questions. Shall we go to the next topic?
Yes, sir. Sir, good evening, sir.
Good evening.
My topic is anesthesia in a post-heart transplant, sir. Posted for bilateral hernia repair, sir. Nowadays, heart to lung transplant cases are increased, and they can present as elective or emergency cases. Before giving anesthesia to the post-heart transplant patient, it is essential to understand the physiology of transplanted heart, the unique anesthetic implications of transplanted heart, and the potential risks such as rejection and infections and immunosuppressant drugs. Heart transplant involves the removal of the diseased heart, in which the aorta and main pulmonary arteries are transected and the heart is partially denervated. The atria of recipient's heart is remain innervated, but conduction does not across the atrial suture line. In spite of the fact that the transplanted heart is a denervated organ, the intrinsic cardiac mechanisms are preserved. It is extremely sensitive to changes in the loading conditions. The Frank-Starling's preserve volume relations becomes paramount in adjusting the contractility. It is commonly said to be transplanted heart preload dependent, as cardiac output depends on the venous return. This has a higher resting heart rate, like 90 to 110 beats per minute, similar maximum heart rate and minimum heart rate, and reduced heart rate variability due to absence of parasympathetic innervation. Transplanted heart recipients have normal sinus rhythm and increased refractive period of sinus node. Many they may have a first-degree heart block, higher rate of pacemaker implantation. The possible reasons of heart block include biatrial anastomosis, organ rejection, nodal ischemia, and inadequate myocardial preservation. They can present as anginal pain, but they won't tell. Clinically, significant atrial and ventricular arrhythmias are infrequent, but ectopics are quite common. Presence of ventricular arrhythmias usually indicates severe acute rejection or allogenic coronary artery disease. We can see through echo. ECG, there can be two P waves. One is from recipient's own SA node and another is from donor's SA node. Tachycardia in response to physiological stress like pain, hypovolemia, hypoxemia is blunted as it depends on the circulating catecholamines. Carotid sinus muscles, Valsalva maneuver have no effect on heart rate. These patients are exercise tolerance, and dose of immunosuppressants should not. Higher risk of developing atrial flutter and atrial fibrillation after a few years later. They can be present at some innervation, and a complete neuronal control has been described after 15 years later. And after administration of neostigmine, the cardiac arrest is common. So we have to decrease the dose of neostigmine. And a frequent complaint of angina, vasovagal episodes. Coronary autoregulations remains intact. Immediately after transplant, left ventricular dysfunction is due to anoxic injury during graft transfer, acute withdrawal of sympathetic support, and after load mismatch. And a rapid increase in heart rate can occur after a few days of life. Pulmonary atrial pressure and pulmonary capillary bed pressure remains increased during the first month after transplant and becomes stable by first year of life. Systemic vascular resistance is increased due to increased blood volume, and due to it is more preload dependent. And well-preserved systolic function and mild diastolic function can be there. Mild to moderate mitral valve and tricuspid valve regurgitation may be present. The myocardial function is abnormal during stress and exercise with a low peak heart rate and a low cardiac output and maximum oxygen uptake. Lack of efferent cardiac innervations, either due to heart rate change alone or together with a submaximal ionotropic response. Coming to perioperative considerations, it is a multidisciplinary approach, and a patient can taking immunosuppressants, and their interactions, we commonly use drugs in the perioperative period. The major side effects are fever, anemia, leukopenia, thrombocytopenia, pancytopenia, the patients mostly hypertension, diabetes, renal dysfunction, and neurotoxicity and osteoporosis. So now we have to know the post-transplant complications and their implications in anesthesia, like infection, dissection, allograft, and cardiac vasculopathy, and any ischemias. Perioperative assessment and pre-medications. The transplant team, as well as attending anesthesiology, surgeons should have a good coordination during perioperative period. Investigations, routine investigations, complete blood count to rule out any bone marrow depression, and the electrolytes, RFT, LFT, and ECG, like any pacemaker activity is there. Endomyocardial biopsy to rule out any evidence of rejection. Echocardiography to assess the ventricular function. Detection of allograft vasculopathy, and coronary angiography. And the biomarkers, usually the patients are increased BNP. It is the detection of any rejection or any coronary vasculopathy. And we have to see the patient exercise tolerance, and dose of immunosuppressants should not be altered and should be continued in the perioperatively to decrease the risk of rejection. And supplement steroids are not necessary for stress coverage, except post-op recipients in whom steroids are recently withdrawn. And we have to get informed high-risk consent and follow NPO guidelines, and DVT prophylaxis and anti-aspiration prophylaxis. Interop concerns and anesthesia technique. Variety of anesthesia technique can be implicated, sir. Either local anesthesia with the sedation, regional anesthesia, and general anesthesia. Either endotracheal tube or LMA also can be done. And it depends on the patient's physical activity and surgeon's performance. Between regional anesthesia, I will go for general anesthesia for herniorrhaphy patients, sir. And the regional anesthesia is usually we have avoided due to not responding to the hypotension, sir. And oral ET tube is always performed. Nasotracheal intubation is contraindicated due to the the potential risk of infection caused by the nasal pleura. Avoid hyperventilation in patients taking cyclosporin and tacrolimus. There is a loss of sympathetic response to laryngoscopy and intubation. The derivative has a blunted heart response, and inadequate anesthetic depth or analgesia. NSAID should be avoided for pain control because increase of the risk of bleeding. We can go for tab block for supplementation. Sorry. Inguinal nerve block and iliohypogastric nerve block. Isoprenaline and dopamine have similar effects in both transplanted and normal heart. Atropine has no effect on transplanted heart. So isoprenaline and epinephrine should be supplement to manage the bradycardia and hypotension. Post-operative care, increased attention should be paid to the preload status and renal function, prevention of infection. Immunosuppression should be continued post-operatively, and blood level is to be monitored, sir. Thank you, sir.
Very good. What are the techniques of doing heart transplant? Surgical techniques.
Heart transplant.
The surgical
Orthotropic
technique,
liver transplant, sir.
no, it is orthotropic, right? The same position we have to remove the deceased heart and then replace with the donor heart. That is agreed. But when attaching the donor heart, what is the difference in the surgical technique? What was done earlier and what is done now? Earlier it was called biatrial transplant.
Yes, sir.
Okay. So portions of right and left atrium or majority of left atrium was retained, and then the donor heart was attached to the leftover positions. It was not attached to the pulmonary artery and the aorta like what is being done now.
Yes, sir.
Okay, so now the current technique is called bicaval anastomosis. So earlier it was biatrial anastomosis, now it is bicaval anastomosis, which is much more easier because it's a large vessel. All you have to do is suture it with the donor pulmonary artery and VC, HVC, and aorta.
Yes, sir.
And so in that case, what happens? this double sinus stimulation is not very frequent. As you said, two pulmonary waves or P waves that is seen because of the native SA node as well as the donor SA node. That problem is not there. In the earlier biatrial technique, after a particular time, the atria used to become very much enlarged and bigger in size, producing more complications and less efficient function. And that is the reason why they have to switch over to bicaval anastomosis pattern. That is
Yes, sir.
number one. And the period after transplant is very, very important.
Yes,
Okay?
sir.
Because the heart function and hemodynamic stability improves over a period of time. It doesn't become overnight. They don't behave normally like renal transplant, where immediately kidney function gets back to normal within 3 to 4 days, and then they start behaving normally. So this does not happen,
Yes,
and
sir.
there is always a looming threat of rejection up to 1 year.
Yes, sir.
So these patients are likely to get a heart transplant patient go in for rejection even up to 1 year of time. So periodically, how do they find out whether there is a early that rejection is present or not? What is the test that cardiologists prefer to do?
Endomyocardial biopsy.
Fantastic. Endomyocardial fibrosis. So they do something like a catheterization and take a small bit of the left ventricular muscle and neural structures and see whether early fibrosis is happening. Okay. So that for that reason, the adequacy and the continuation of immunosuppression for quite some time is very, very important in these patients. And as you know, whenever a patient is on immunosuppressant, the chances of contracting any infection is very high, and you have to be careful with that so that they don't. And the physiological function. So the two things that we have to know in a heart transplant. One is the anatomical procedure that was done. The second thing is the behavior of the heart in the physiological function manner. As you said, it will have an intrinsic higher heart rate because the SA node is not controlled by the nervous system. It is a denervated SA node. So it acts on its own intrinsic activity. So the heart rate is always on the higher side between 90 to 110. And the second thing is it cannot respond to the situations, as you said, for pain, hypoxemia, or fluid underload or overload. Nothing, it will not respond to all those things up to 3 to 4 years. After that, gradually it develops. When will it become a normal heart?
15 years,
When
sir.
will it start? 15 years, very good. So at the time, if it is 15 years and you give GA and give minostickment, can there be any complication?
No, sir.
No.
But we have to reduce the amount. We have to reduce the dose.
Minostickment can sometimes
Some-
produce
some-
severe bradycardia and arrest.
Yes,
After
sir.
15 years, when the heart behaves in a normal way,
Yes, sir.
it starts responding to myostatin in a very severe way, and that can produce a severe bradycardia and hypotension.
Yes, sir.
And that is the reason why the period of post-transplant time is also very, very important in these cases. And in case they develop any bradycardia intraoperatively, only isoprenoline and
Okay.
epinephrine can improve the heart rate. So these drugs should be kept ready. That is a very important thing. And once the cardiac function has stabilized by over a period of time, these patients have been operated using all anesthetic techniques from local infiltration to central neuraxial blockade as well as general anesthesia. And when you give central neuraxial blockade, which is a common technique we adopt for any intraumbilical procedures like distal neuraphy, then the problem that we have to face is the sudden hypotension, which normally happens in every patient. Okay? So in these patients, which is the drug of choice to correct the hypotension? Supposing you plan to give a single shot spinal, your surgeon is a very fast surgeon, you will finish the surgery within 45 minutes. You plan to give a short-acting drug like chloroprocaine and finish it off. So, and there is a hypotension. So what is the drug of choice to correct that hypotension?
Isoprenoline and dobutamine, sir.
Phenylephrine can be given. It will react to phenylephrine. Okay? So phenylephrine is a drug which can be given safely In fact, you can give it a bolus and then start infusing it so that, or prophylactic infusions also have been given. Before administering spinal itself, you start up the phenylephrine infusion and you then give the spinal, so you can always manage the hypotension without any issue. And preload is very, very important. So patient should, during the time of starvation itself, you start an IV infusion slowly, so that this denervated heart is a preload dependent heart. So any hypovolemia in the pre-anesthetic period, that will cause a very severe hypotension intraoperatively. So preload should be taken care of all the time, and all precautions for preventing infection, because these people are immunosuppressed, is also very, very important. So sterile aseptic techniques can be used. So the options are all the three. You can give when a hernia block, you can give low spinal with phenylephrine infusion support, or you can go for GA, and in GA also you can go for either AT tube intubation or LMA also has been approved. And of course, there also you have to practice the sepsis so that you don't produce any infection in this patient. Okay? So that is the thing that you have to know. So just share my screen. The post cardiac transplantation for inguinal hernia repair, anesthetic management. So the problems we have to face in this case are denervated heart, patient on immunosuppressive therapy, risk of rejection, and proper selection of anesthetic technique. These are the things that we have to keep in mind. So physiology of the transplanted heart, the removal of involves removal of the disease cause and placing the donor heart in the same position. So just like liver transplant, this is also orthotopic. Whereas renal transplant is heterotrophic. You don't place the kidney in the same position of the native kidney. You put it in the iliac fossa elsewhere, attaching into the iliac vessels. Whereas here it is all done in the same position. And the aorta and pulmonary arteries are transected, and cardiac plexus is interrupted, and heart is partially denervated in this condition. And so here you can see this is the way they do that section of the pulmonary aorta, pulmonary vessels. Then these are the suture lines. So this is the patient's disease heart, which is removed initially. And then the donor heart is put in this place after removing and it is done under cardiopulmonary bypass circuit. Although the transplanted heart is denervated, the intrinsic cardiac mechanisms are still preserved. So that is the reason why, because the SA node rate is always higher than the AV node and the other conduction system. That is the reason why you have the resting tachycardia or higher heart rate. The heart is extremely sensitive to changes in loading conditions. The Frank-Starling pressure-volume relationship becomes paramount in adjusting the contractility. So preload is very, very important. And so it is the preload dependent cardiac output and depends on the venous return. And it has a higher resting heart rate of 90 to 110 beats and reduced heart rate variability. And all of them because these changes are because of lack of parasympathetic control. So it is predominantly sympathetic activity only. So parasympathetic innervation grows over a period of time, not immediately. And the transplant heart recipients have normal sinus rhythm and the increased refractory period, which produces a slight delay in the conduction, like having a first degree heart block. So about 20 to 30% of these patients may require a pacemaker also. So if they have pacemaker, that history is there. You have to take care of all the precautions that you will execute for pacemaker implanted patients. The other reasons for heart block are the biatrial anastomosis, organ rejection or nodal ischemia, and inadequate myocardial preservation during the transplant procedure. These are the other reasons for the heart block. And this is the ECG of a patient after heart transplant, you can see there are two P waves before the QRS complex happening. This is the normal ECG in a heart transplant patient with a double atrial activity, and tachycardia and response to physiological stress is blunted in these patients. And carotid sinus massage and Valsalva have no effect on the transplanted heart. There is always a risk of atrial fibrillation or flutter due to some degree of renervation constantly trying to happen. And complete neuronal control happens only after 15 years of successful transplant. So it takes that long time. And patients may have complaint of angina, vasovagal episodes, and cardiac arrest after neostigmine administration after this 15th year of transplantation. So at the time, if any surgery is happening in this patient, you have to be careful. And coronary autoregulation remains intact. It responds to the metabolic demand. So normally, the acute coronary syndromes are quite rare in the transplanted heart. And PA pressure and pulmonary capillary bed pressure remain elevated during the first month after transplant and become stable by first year. So that is another reason you must know the interval between the transplant and the incidental surgery that is happening. And rapid improvement in ventricular function, cardiac output becomes normal within a few days of transplant also. The well-preserved systolic function, and there is a mild diastolic dysfunction. Mild to moderate tricuspid and mitral valve regurgitations are present. And it is subnormal during exercise and stress with a low peak heart rate and low volume, maximum oxygen uptake. And this can cause lack of efferent cardiac innervation because of the efferent cardiac innervations which are not developed well. Submaximal inotropic response. Now, post-transplant complications and their implications in anesthesia are infection, rejection. This particular pathology that can happen, what is called allograft vasculopathy, which will affect, that may be the reason for coronary heart disease, not the development of any atheromatous clot or anything, but allograft vasculopathy is for the major problems. And patient may have comorbidities like diabetes, epilepsy, hypertension, etc. And beta blockers are best avoided in these patients for treatment of any hypertension. So giving any type of beta blocker like metoprolol, bisoprolol, or even carvedilol, all that can be totally avoided in these patients. And interactions between immunosuppressive drugs and anesthetic agents, you should know, because some of them are very, very highly reactive. So among the inhalation agents, isoflurane seems to be the safe drug. Clearance of oral, that also can affect the clearance of cyclosporine, which decreases, and steady level maintained with IV cyclosporine. And most of the inhalation agents are well tolerated unless there is a significant heart failure in them. For thiopentone, there is no contraindication or no interaction. Midazolam increases blood level of benzodiazepine, so you have to reduce the dose of midazolam. Propofol and etomidate you can use in the normal dosage. And with regard to the muscle relaxant, opioid muscle relaxant, most of the muscle relaxants are safely used, especially atracurium and cisatracurium. And neostigmine, as I said, after 15 years, when the heart gets fully innervated, they have to be very, very careful because that is supposed to have cause of bradycardia and cardiac arrest. And opioids, their effect on cyclosporine increases the analgesic effect, especially produced by fentanyl. So the dose of fentanyl can be reduced if the patient is receiving large doses of cyclosporine for immunosuppression. Local anesthetic, bupivacaine can be safely used throughout for any regional technique without side effects. That is Earlier, we are worried about the cardiac depressant effect of bupivacaine, and now we can use levobupivacaine, which is less harmful than pacemaker bupivacaine. So that has also been approved. Preoperative assessment and pre-medication, ECG to assess the graft function and arrhythmia, if any, and about 5% of the patients may be presenting with arrhythmias. Endomyocardial biopsy to rule out any evidence of rejection, because it will not be very evident like in the blood picture or anything. Echocardiography to find out the ventricular function, and coronary angiography reserved in patients with suspected allograft vasculopathy. And laboratory parameters, you have to do a complete hemogram, electrolyte, renal function test, liver function test, and biomarkers like BNP to rule out any left ventricular failure. And that can also help in detecting the allograft rejection and coronary vasculopathy. So even if the patient is not suffering from frank or overt left ventricular failure, BNP raised is the earlier indicator of allograft rejection and coronary vasculopathy. And oral cyclosporin should be administered 4 to 7 hours before surgery to maintain the therapeutic blood levels. This is the drug that they have been using. And supplementary steroids are not necessary for stress coverage in these patients, in whom steroids are accepted in whom recently withdrawn. So if it has been more than a month of stopping steroids, there is no necessity to replace it with hydrocortisone or dexamethasone intraoperatively. Intraoperative concerns, local, regional, neuroleptic, general, all have been used successfully. Local, you can do a hernia block suitable in thin patients with reducible hernia and a small sac. Regional, like central neuroaxial blockade, combined spinal epidural after adequate preloading, and use of phenylephrine to treat hypotension also has been successfully done. And GA usually preferred as there is possibility of impaired response to hypotension after spinal or epidural. And you can do induction with etomidate, because that will more cardiostable induction agent. Muscle relaxant, you can use intracranium or supratracheal. The airway can be maintained either with endotracheal tube or LMA, and the maintenance of anesthesia can be oxygen, air, and either isoflurane. For pain relief, you can use fentanyl and multimodal anesthesia with inguinal and iliacogastric nerve block or tab block. Avoid hyperventilation, and type of intraoperative monitoring depends on the type of surgery as well as the availability of monitor. For a hernia surgery, simple monitors like NIBP, ECG, pulse oximetry, PCO2 are more than enough. And response of denervated heart to various cardiovascular drugs. So these are all the common things which may be asked. Atropine does not have any effect on the SA node or AV conduction. Cannot be used for bradycardia in emergency. Dopamine and dobutamine, they increase the SA node and AV node conduction, and they're effective on heart rate more than normal heart, especially dobutamine. And epinephrine and norepinephrine have their usual effect on all these parameters and the tissues. And isoprenaline increases both AV node, SA node, but it decreases the BP because of vasodilatation. And but cardiac output will be increased because of the increase in cardiac contractility. Phenylephrine supposed to increase the BP. Other things it does not have, so that is the reason why it can be used as a agent to counteract the hypotension that is caused by the spinal. And digoxin may decrease the AV conduction, but SA node it doesn't have any action. And isoprenaline and epinephrine should be readily available to manage bradycardia. Post-op care, preload status, monitor renal function, and prevent infection. Immunosuppression should be continued as early as possible. Okay, so these are all the things that we have to know about cardiac transplant patient coming for an incidental surgery. So anatomy of the surgical technique, physiology of the behavior of the heart, immunosuppression importance, and then always have rejection as an important complication in the back of your mind. And of course, the cardiologist also will be knowing about and doing things to find out whether the subtly rejection is going on. So that can be identified by raising DNP as well as endomyocardial biopsy. So these are the things that and which drug to use safely also is an important knowledge that all of us should have. Okay,
Yes, sir.
right. Shall we go for OSCE?
Yes, sir.